This is a tracing where the patient may have normal brain activity and then they start having rapid misfiring of the neurons. You can imagine as you're looking at a strip that a person does an EEG and maybe they miss this area and this is all they see. And then they say this person doesn't have seizures. But right before they hooked up the electrodes, maybe all of these things are going on. So that's why we need more than one EEG. Finally, we're at medical management. We want to decrease the amount of seizures. It's aimed at decreasing injury during a seizure, decreasing the amount of seizures, and any untoward effects from a person having repeated seizures. Medical management is anti-epileptic drugs. We talked about earlier the fact that a patient may be tried on several drugs and also would need blood levels of the medication to make sure that they're therapeutic. Client and family education. What do you do during a seizure? How do you monitor the patient? When should you call 911? Seizure precautions. Make sure you review them again. Monitoring drug levels of the medication is going to be important, and surgical management could be vagal nerve stimulator, or it could be surgical excision of the area. Remember, we talked about that it could be a particular area of the brain that's causing the problems, especially if a person is going into status epilepticus. So that area of the brain, if all of these things did not work, then surgical excision of the brain is something that could be done. So if we look at anti-epileptic drugs, again, we refer to your chart on 59-9, but your text talks about emergency management for a seizure, and that's 59-7, no, 59-8. And it talks about seizure disorders and epilepsy collaborative care in 59-7. So make sure you look at the collaborative care and then seizure precautions in your text. And then the drug therapy is table 59-9. So please look at those. Anti-epileptic drugs. First line would be your carbamazepine or Tegretol. You can look out for respiratory depression, irritations to the stomach, serious liver toxicity, and aplastic anemia. So you want to make sure that you talk to your patient about that and you assess their respiratory status. If it's irritating to the stomach, you may give it with food. And patients may also be put on medications to coat the stomach. If it can cause serious liver toxicity, then we are going to want to monitor the patient's liver function test. Phenobarbital is another drug. Sedation, nystagmus, ataxia, and agitation can occur. So if sedation occurs, your phenobarbital may be a drug. It's been around for a long time. It may be a drug you may not want to use with your elderly patients. So for phenobarbital, please see the gerontological considerations. Just, if you think about sedation and the elderly and how that they filter things out slower, this may not be a first-line drug for them. Phenytoin or Dilantin is commonly used. Nystagmus, gingival hyperplasia, anemia, hirsutism, osteomalacia, prolonged therapy. You want to teach the patient to increase the vitamin D in their diet and monitor the calcium level. Back to the gingival hyperplasia that may occur when the patient is taking Dilantin. I think we've talked about gingival hyperplasia before, but it can cause gum disease, it can cause bleeding, it can cause just overall swelling and irritation of the gum. So you want to make sure the patient is brushing, cleaning their teeth, and seeing a dentist on a regular basis. So look up gingival hyperplasia. Patients may also be placed on valproic acid, which may cause sedation or ataxia. Valproic acid may also cause alopecia, so you want to make sure you point that out to your patient. It's also important for you to know that anti-seizure medications, the patient must be weaned off of them. They should not stop them abruptly. They should always talk to their physician. Abrupt discontinuance of seizure medications may precipitate seizures. Remember, we're giving the seizure medications to control or prevent breakthrough seizures. If you're taking medications and you're therapeutic, you shouldn't be seeing seizures with the patient. So 1/3 of the patients who are diagnosed with epilepsy may require 2 or more medications to control their seizures. Tegretol is another one of your anti-seizure medications. That's the first one we talked about. You want to make sure that patients know that they should not take this medication with grapefruit juice. It can precipitate or have an effect on the effectiveness of the drug. Neurontin and Keppra are safer choices for seniors. Remember, your Dilantin can cause toxicity quicker in your seniors, so you want to use those medications with caution. Please look at the nursing diagnoses and make them 3-part in areas where it is appropriate, except for your risk for aspiration. That will aid in your studying. Make sure you look at nursing implications. You want to get a good history for your patient, including current medications if they have any allergies, baseline vital signs, oral drugs they should take regularly the same time each day. They should take with meals to reduce GI upset. They shouldn't crush or chew any extended release medications, and often these medications may be extended relief. So all these things can help with the patient's knowledge deficit, especially when this is a new diagnosis. If the patient is NPO for a procedure, you want to contact a prescriber, because anti-epileptic drugs need to maintain a blood level to prevent breakthrough seizures. So you want to talk to the doctor about that because they can bring on seizures. Now, what are some nursing interventions? What do we want to do? Again, I talked about keeping a journal a little bit earlier. So advise the patient to keep a journal to monitor response to the anti-epileptic drugs, how often they have a seizure and what it looks like if they have witnesses, any untoward or adverse effects that happen. So injury prevention during a seizure, again, we said we put the patient in a rescue position. We want to make sure the patient is having drug levels monitored so that we will be able to see if they have therapeutic effects of the medication. Again, we want to inform patients to be weaned off the medication and also wear a medical alert bracelet. Maintain airway breathing, your ABCs, oxygen and suctioning as needed. Remember, we're not putting anything in a patient's mouth during a seizure. Monitor start, duration, characteristics of seizure, and post-seizure. It's important to document that. When we talk about monitor start, you want to get the whole duration. Remember, if a seizure is under 5 minutes, it is not an emergency in an epileptic person. A seizure where people do not recover from it and they continue to have seizures is an emergency, and we'll talk about status epilepticus in a moment. Note if an oral or other circumstances lead to the seizure. It'll help us realize what type, or whether it's a partial or whether it is a generalized seizure. Again, we can't say any of these things more. As a nurse, we don't want to put tongue blades in the patient's mouth, and we want to teach their families not to do that either. We want to protect a patient who's having a tonic-clonic seizure by patting the side rail, bed in the lowest position, loosening clothing. We want to monitor vital signs post-seizure, including neurological assessment. We said it's not a medical emergency if a person who has epilepsy has a seizure, but we do want to document it, and we want to inform the physicians that their patient did have a seizure. They may want to make some adjustments in medications. Maintain IV access. If the patient goes into status, the 2 medications that they give are typically Valium or Ativan, and you want to make sure these medications are typically given by an IV route, and if your patient does not have IV access, then it will slow their treatment. minimize stimuli that might cause a seizure. Remember, we said there could be some things that bring on or evoke a seizure. Remember that there is no cure for a seizure. Treatment is aimed at controlling and prevention. Drugs act to stabilize nerve cell membranes and prevent spread and rapid firing of discharge of neurons. Doctors usually start the patients on one medication at a time. After a patient has a seizure, we want to be careful to orient or reorientate them to their surroundings. Educate peers on seizure first aid if the patient gives you, if the patient gives you permission to educate their peers or their family. Remember HIPAA. Monitor side effects of medications and compliance with meds. You want to make sure you make drug cards for the different classifications of meds and tell the patient how important it is that they take their medications and that they don't take them abruptly, because it could cause rebound seizures. Okay, so finally let's talk about status epilepticus, which is that complication of a seizure. Status epilepticus can occur with any type of seizure. The brain uses more energy than the body can provide during these rapid seizures, where the patient does not have an opportunity to regain consciousness or are able to be aroused. This causes the neurons to stop functioning, and it can lead to permanent brain damage. So you want to make sure you have in your mind that this can lead to permanent brain damage. So we want to prevent this from happening. So what is this? A prolonged seizure activity over 5 minutes, longer repeated seizures in short periods of time. And know that this is a neurological emergency and it must be treated immediately. We want to monitor the patient's airway. We want to make sure we put them in a rescue position. We want to make sure that we have suction equipment available. We want to listen to breath sounds. We want to monitor vital signs. Possible complications that can be fatal are ventilatory insufficiency, hypoxemia, cardiac dysrhythmias or disturbances, hyperthermia, and systemic acidosis. So we want to make sure that we are monitoring the patient and reporting changes or abnormalities to the patient's physician. So in systemic acidosis, the patient's pH on laboratory tests will be less than 7.35. The kidneys are not able to form bicarb, so you'll see bicarb diminished. This situation can lead to coma and death. This usually comes as a result of lactic acidosis. Remember what's happening in a seizure. There is rapid, jerky, tonic-clonic movements, and so you have a buildup of lactic acid in the patient's body. We talk about lactic acid buildup in many other sections. So know that this can lead to systemic acidosis, a decrease in pH and bicarb, and it can lead to coma or death if it's not fixed. That's your systemic acidosis. So the treatment needs to be rapid-acting IV anti-epileptic drugs. The most common are short-acting, used first either Ativan or Valium, and then it's followed by long-acting medications, which would be your phenytoin or your phenobarbital, and the physician would choose which one. Again, these medications are given IV. This is why we said this patient needs to have a functioning IV, and a large bore IV would be recommended for this patient. Again, after a patient experiences status epilepticus, you want to make sure you recover the patient, you document appropriately. This patient will probably be in a one-on-one observation with the healthcare provider. You'll be monitoring them as the nurse, checking vitals and giving medications as prescribed by the physician, or you may even have standing orders as to how to treat this patient if they would have repeated seizures. Diastat gel or the rectal gel is is Valium that may be given to the patient to control or stop their seizures. So that may be ordered also. Please continue to make sure you read your chapter regarding seizures, regarding also there is something in here, delegate, being able to, what you would delegate to non-licensed personnel, what you would delegate as far as taking care of your patient to non-licensed personnel, and what the scope of practice for the RN is. Make sure you look at that. That is all for now.